Thank you very much, Engveld. And it's a real honor to be here. Thank you. I'm quite overwhelmed at how many of you are here at this conference on competency-based education, and really congratulate you for taking it on and moving ahead with it. So I am from Halifax in Nova Scotia, which is on the Atlantic Ocean. We're the province that sort of juts out into the Atlantic, except we're at the sort of 44th parallel rather than the 65th or wherever you are. However, there are some similarities that I've noticed already. Our airport in Halifax is out of town, in the woods, in the middle of the forest, which I noticed coming here. We have a lot of rain, which I've noticed coming here. We arrived on Friday, and I've really been honored to be able to spend some time here. And this is just a picture. This is Lunenburg. I actually live outside Nova Scotia, about an hour. So this is sort of looking out from our house, and I just wanted to show you that the sky is very similar to here. So I think that we Canadians and Norwegians are similar in many ways. So thank you I wouldn't be able to give this talk in Norwegian. So please, Engveld has been translating some things for me as the talks have gone on. And I would just ask that if I say something that you really can't get, just put up your hand and I'll ask Engveld to translate as we go along. It's meant to be an informal talk. Sound okay? So the kinds of things that I'd like to talk about are review the evidence for effective feedback and coaching and clinical supervision. And although I couldn't understand all of what Paul was saying, Engveld was able to translate some for me. And I think that you're going to hear, and you probably recognize yourselves, that the principles of communicating with learners and giving them feedback are very similar to the principles of communicating with patients and trying to encourage them to take on their treatment regimes and so forth. I'd like to talk about the learning culture. I think we've heard some of that in both the talks this morning. I'll describe the feedback model, the R2C2 model, which we've been sort of working on for a number of years to develop. I'll explain that in some depth. And then, being an educator, I always find that sort of having a case or a scenario to think about is often helpful for learning. So I'm going to start with that case, and I hope you don't mind. So I'd like you to consider Chris, a resident at the end of his first year in internal medicine. He's been on your service for the past week, and he'll be with you for several more weeks. He seems to have a good basic knowledge base, but you wonder about his ability to integrate that knowledge and to come up with a diagnosis and a treatment plan. He seems a bit hesitant, and importantly, you've noted that he missed a diagnosis of diabetic ketoacidosis in a sick patient earlier this week. So I'd ask you just to reflect upon, if Chris were your resident, how you would introduce a feedback conversation with him, and how you might coach him to improve. So I'll just give you a second or two to think about that before I move on. So what do we know about feedback? And again, I think Paul referred to some of what we know. This is a definition offered by Monica van der Ritter from the University of Utrecht. It's specific information about a comparison between observed performance and a standard, and given with the intent to improve the trainee's performance. I think we found certainly in North America that sometimes feedback is given not necessarily with the intent to improve, but and it's about the information. This is an older definition. It was focused on that information, that gap. This is sort of newer way of thinking in the medical education literature. There's quite a bit now being written about how a feedback is a conversation. And I put up this model of throwing a frisbee back and forth. It's very much a back and forth conversation instead of that, that old-fashioned patriarchal sort of top-down delivery. It's now considered a conversation in the same way you have a conversation with your patient. And it's really about, if we remember, the goal is really enabling the learner to develop, to improve, and become the very best that they can be. And I learned this word from a workshop that I was doing with program directors in postgrad education. And she said that her goal, whenever she met with a resident, she wanted to do something that would help them to become the best that they could be. And that's just always resonated with me, with a really good goal for feedback. So, however, it's not easy, as you well know, and so giving feedback in a clinical scenario is really complex. And so I'm really going to talk about it from these three perspectives. So from the supervisor, your role and what feedback is, from the resident's perspective. And are there some residents in the room? I'm curious, any residents? Very good. Because we've learned in Canada that involving residents from the get-go in any change is really important for helping to enable that change. And then the culture, and I made the culture the biggest circle because we know that really influences what we do, the systems that we work in, and what we're expected to do. So first of all, to the supervisors. And you'll hear that some of these, you may have heard some of these before, the characteristics of effective feedback. So it's specific. It's not just, you're doing well, don't worry. It's very specific. Timely. So it's at the time that you've observed that learner or at the end of the day. It's not, 2 weeks later when you sort of think that you should give it. So timely. It's on observed behavior, and I think I heard Paul talking about observation, trying to observe and so that you have specifics. Observing gives you those specifics to talk about. It's about behavior that can be changed. So it's not about somebody's personality characteristics. It's about a behavior. When I saw you do this procedure, I observed such and such. This one keeps giving us challenges. It's related to a standard or a competency level. So this is a benefit of competency-based education, that having some shared standards about where residents should be and what they should be doing, so that the feedback you're giving isn't just about your own inner belief, but about generally accepted standards. And this now comes some of the newer thinking about feedback, that you try and seek the learner's views. In the same way as patient communication, you try and seek the patient's views, you try and seek the learner's views, you demonstrate interest in them, and then you coach for improvement, which I'll spend more time talking about. So those are sort of the characteristics of effective feedback, and then I'll talk a little bit more about 3 criteria in particular. The first one is that it really needs to be based on observation. And and this is in research. We've done extensive research with residents and with physicians, practicing physicians as well. And and what they've told us, that if you don't observe me, then how do you know what I'm doing? How can you give me helpful feedback? And so this was a quote from a resident in some qualitative research that we've done, is, I don't pay attention to that supervisor's feedback as he's never actually observed me. I mean, and you can imagine, putting yourself in that situation, that when someone observes you, they can be much more specific. And that to think about, this notion of coaching, thinking of sports coaching or music. I'm sure some of you are, everybody in Norway is involved in sports, especially skiing. I know that, so I don't even know if you have, but for the ski coaches, for those of you or your children have ski coaches, that it's really that observation. That's what the coach uses to help the student, the learner, the athlete get to the next level. And the same in music. If you have a music teacher, it's observation that really gets you to that next level. This was said by Jack Ende in 1983, a long time ago, one of the first to write about feedback and communication. And he said observations are the currency of feedback, and without it, it's just feedback in word only. It's not really it. Criteria number 2, it's provided in relation to a standard. And again, I've mentioned that having a competency-based model where standards are becoming more explicit, so at the end of in true competency, perhaps years aren't used as a measure, but to think about, so at the end of the first year, so thinking of Chris, at the end of that first year of internal medicine, what should he be able to do? What would be the expectations regarding his designing a treatment plan? And then some residents have said to us this sentence at the bottom, like, I don't know what good looks like. I haven't seen this procedure performed, or I haven't seen this kind of communication before. So I don't have a picture in my mind of what I should be doing. So part of supervision is giving our learners, that mental picture of what good looks like. And number 3, this is the last criteria I'll speak about. It's specific and uses words. So again, that specificity, not numbers. So in Canada and the US, we use a lot of Likert scales, and our residents get a lot of numbers, like a scale of 5, 1 to 5, so they're maybe a 4 out of 5. But what they tell us, and I'm sure you can imagine as well, that being 4 out of 5 doesn't really tell me anything. It doesn't tell me how to improve. So that you provide the specifics of what you've observed and what needs to be improved, and that gives you the data so that you can really coach the learner to the next level. This was from one resident. You normally get very vague responses like, you did that okay, or you did that very well, but no one ever takes that extra step to describe what you did well. And so that reminds us, too, that our residents who are doing really well need feedback about what they're doing well so they can even get better, aspire. And again, thinking of the sports or music coach. Ingve, would you just let me know about time, about where we are, okay? Because sometimes I can go on a bit long, and I don't want to do that. 15, okay, so I'll speed up a little bit. So resident considerations are, in Canada, this often happens that there's a group of residents around a patient's bed with the physician, and this is what may be going on in the resident's head. They want to appear confident and competent, and therefore they may not ask for feedback, or they may not speak up for fear of saying the wrong thing. They may not accept constructive feedback, as we've heard already, and yet residents feel that they don't get enough feedback. And so this resident said, I've never tried to ask for feedback because you want to portray competence, so we have to remember this. And then another quote, sometimes I think the reason why I take feedback so personally is because we get so little feedback. And so that if I only get bad feedback, it really makes you feel like you must be the worst doctor ever. And so again, speaking to that notion that we should be giving feedback for those that are doing well, and specifically what they're doing well, and balancing that with what folks need to do to improve. The culture, I'm sure that you can relate to one or both of these pictures that are in Canada, and I'm sure here your healthcare systems are really stretched, incredibly busy. So it's not only what's going on in your clinical setting, it's the bigger healthcare system within your hospital, within your region, within your province. And then layering upon that education and how education fits in. So culture is huge in giving feedback and having the time and space to do it. So the culture, I'm going to talk briefly about sort of the ideal culture. It's a way of thinking. So we think about assessment and feedback, for learning and development. I think in the past we've only thought about feedback and assessment of learning. Are they good enough? But now we're really trying to think about how do we do this for learning? And how can we promote this within a competency-based culture? This slide you may, and I'm just thinking Jason may have this slide in his set as well, but it really emphasizes that our job as educators of residents is really to take them from that. It may not be exactly a novice level, it may be the beginner, advanced beginner level, but it depends. In communication skills, they may be at a more novice level, and through feedback and coaching to take them up through the various levels. And you know, for us in Canada, I think we found this just a really helpful model that, you know, we're always talking about helping them to get better. This slide, I won't go through it in detail, but I will leave my slides, and they can be distributed if you want to take a look at them. You know, just describes in detail what each of the levels means. A novice, as you know, is very rule-driven. You know, an advanced beginner can begin to think a little bit, but not too much. And so it's really, you know, getting residents up to competent and proficient, I think, is where we're heading. This notion by Erickson, you may have heard of deliberate practice, one of your Scandinavian colleagues, and that, you know, deliberate practice requires being focused, setting a goal, and it involves feedback. And it's not just about trying harder, but it's about getting feedback guidance so that we actually improve. Again, this is another way of thinking, and so you have the levels, and it's feedback. Feedback and coaching is really the medium by which we are able to help our learners learn, to help our residents learn. So why are we thinking about coaching? Because it focuses on outcomes, which is what we're thinking about. It's longitudinal, just think of sports. I really like this quote. It's from a Canadian colleague, Chris Watling, and it really sort of plants in our minds this kind of thinking, in that coaching is a change in thinking. It's about the finite. It's not about the finite exercise of teaching something to someone. It's about the infinite exercise of continuous improvement. So it's really about that. It's longitudinal, it's ongoing. And you just think about the best athletes and musicians that trust in the power of coaching to get them to be better than they ever thought they could be. And that's what we would like to strive for. Competency-based education is similar to this notion of continuous improvement. We focus on growth, we need to observe the learners, and we want to create this culture where it's safe, where it's convenient, where it's comfortable for them to learn, that it's safe, respectful, humanistic, positive, in the same way that we want a positive culture for our patients. So I'll spend the last few minutes talking about the R2C2 feedback model. I have 20 minutes more? Oh, okay. Thank you very much for that. So I'll take some time to go through this with you. So this arose from research, and I think as Ingveld said at the beginning, that I was involved in initial research with physicians in Nova Scotia where they did not accept negative feedback. It was a formalized program, and they received reports. It was a multi-source feedback program, and they received reports with their scores on from patients, from medical colleagues, and from other healthcare professionals. And it was a performance review program for improvement. So it was sold to them, or theoretically sold to them, as this is feedback for you to improve your practice. However, we were very surprised as in those who received the feedback in the lowest 30th percentiles said, we don't agree with this feedback. We're not going to take it on, and we're not going to use it. And so this was a real wake-up call for us as researchers, because you sort of think like it's just intuitive. You give somebody feedback, you tell them how to improve, and they're going to go off and do it. However, this was a real wake-up call for us when we realized that people didn't take it on, and for all kinds of reasons. When we get feedback that tells us that we're not as good as we think we are, it's really emotional, it's discouraging, it's disappointing, it's all kinds of negative feelings. And so we've learned, through this research that we really have to pay attention to those negative feelings and then move on to help the learner accept it and to improve. So again, it's about having almost a therapeutic relationship with that learner so that they can feel comfortable talking about what they're not doing well with. And so that led to this body of research around feedback. How can we have these feedback conversations in a way that will help learners and physicians, take on feedback and use it so that they'll, be on that continuous quality improvement slope. This is the model. And it has 4 stages, and it's R2C2 because there are 2 R's and two C's. So the first R stands for relationship. I'll talk about each one in some time, and I can send some more material about it if you're interested. The second R is exploring the reaction, so that emotional reaction that I just talked about when the doctors in Nova Scotia received some negative feedback. And then once you've explored the reaction, to move on to the content, and then this notion of coaching for change. And we've learned in our research that it's that coaching piece that is really the most novel, the most challenging for supervisors to take on. So I'll spend a little bit of time talking about each one of those. First of all, just to review with you the overall purpose of the R2C2 model. It's to promote feedback use and performance improvement. And it's about asking questions. And I believe I heard Paul say in his session on communication, it's really about asking the patient questions. And so this is similar as we know, to engage someone in conversation and let them see that you're on their side. It's really important to hear their views. So asking questions to encourage the resident to reflect on their performance and their feedback, to seek their self-assessment, like how did you think you were doing and how does this compare? Promote that acceptance. So it's almost, when I use the term motivational interviewing, is that something? I see a few head nods. That really, I know it's used extensively in North American family medicine, internal medicine. So a way of interviewing patients to help them make a major change in their life. It's often a lifestyle change, so to help people stop smoking, start exercising, all those kinds of things. But it engages the person. Promote acceptance, foster self-direction. Part of what we want to achieve through resident education is helping residents to be self-directed so that they can graduate and become doctors who will continue to grow. So they need to develop the skills of self-direction, and then this coaching for change. So the first stage is building the relationship. And we've just learned lots about this, as we often would sort of, often go in and just tell a resident, well, this is what you did wrong, and this is what you have to do better, without doing this little bit of a relationship building at the beginning, even if you know the resident quite well. So how is this rotation going for you? Tell me about what you enjoy. What challenges you? Finding out these kinds of things. Thinking, what are your goals for this particular week that we're working together? What are you trying to work on? And then if you've just observed them doing something, say, well, tell me, how do you think you did in performing X in the interview with that patient or that patient examination or that procedure? What didn't go as well as you hoped and what went well? So you can see there that you're really engaging the learner and you're building that relationship. You're asking open-ended questions to really help them feel comfortable. Relationship. Stage 2 is the exploring the reactions and the emotional responses to the feedback. And so this is where we learn from that study with doctors in Nova Scotia who didn't want to accept their feedback, that we went back and interviewed them and learned that we really had to hear their stories. What we learned is that giving negative feedback can be like breaking bad news. Is that a term that you use? In communication, when you're giving a patient bad news, it can be similar. So being very sensitive and using some of the same steps. So we want the resident to feel understood and that their views are heard and they're respected. And so asking them outright, so what did you think of my observations, of what I said about you? what are your initial reactions? Did anything surprise you? And we find that word surprise is really helpful. How do my observations, compare with how you think you are doing? So asking them directly. It sounds, and questions like, it sounds like this feedback was really disappointing for you. Can you tell me how you thought you were doing? And it would help me to understand that. And just, having a conversation. It's difficult to hear feedback that is disconfirming. That we all know that. Acknowledging that in the conversation can help the conversation move ahead. So what you're doing in this stage is really trying to deal with those emotional reactions if necessary. Then once the emotion has been dealt with, in the same way as having a patient conversation, you would explore the content. So for the resident to be clear about what it is that you've said or what you've shared, and the opportunities, and this is beginning to get into the positive side, the opportunities, what this means for your change and development. So what are your thoughts now? Is there anything I said that didn't make sense? So that clarification. What struck you as something to focus on? And this is the real essence for moving into the coaching phase. What is it from this observation, either from taking out these sutures, what did you learn that you can do better, or from this interaction with a patient, what did you learn that you could do better and can work on? And then for the coaching phase, we've looked into the science of changing behavior and implementation science for these tips. So for the resident to engage in developing a plan, an achievable plan. And we've learned through our research that doing it together with the supervisor, so instead of the supervisor telling them you need to do this, this, and this, or instead of the resident doing it alone, doing it together. So asking questions is, what was one thing you want to target, in the next week, for example. What would be your goal? So helping people to really visualize what would be your goal in improving this. What actions will you have to take? So if it's around communication with a patient, how are you going to improve that? Will you observe someone else who's an excellent communicator? Will you watch some videos on communication? What will you do? What might help you? And what might get in the way? Because we all know when we're going to make a change, there are many things that get in the way. There's not enough time, not enough effort, et cetera, et cetera. And so what might help you do it and what's going to get in the way? What resources do you think it's achievable? And this is a piece that we've worked quite extensively on, and we're still continuing to study quite how to coach effectively. This, 5 minutes? Okay, thank you very much. This is we call it the Learning Change Plan, and I'm not sure if you can see it all, but it essentially asks all those questions that I just went through. This isn't feasible to do, every day. It might be feasible to do if you've been working with that resident, Chris, for a week, and you want to set out a learning plan for him that you might sit down together and decide how you're going to proceed. We found in our study with residents, it was an international study, that the residents and supervisors did use this plan, and I'm happy to share it with you. So describe specifically what you want to do, what specific actions, when will you begin, when do you think you'll see results, identify the resources, what will you need, what will get in the way, and how will you know when you've achieved your goal, which is important. The other piece that we've learned is follow-up, is that following up with that resident to see, have you been able to make those changes? Can you tell me how you've improved, so that you don't just leave them and expect them to do it on their own. So the whole feedback facilitation goal is really to try and remove that sense that external feedback is out of my control and it's something bad, to try and transition it to, this is data. I now have data about my performance that I didn't have before, and I can use it to improve. So trying to instill that very different way of thinking. So in summary, I'm going to go back to this notion that feedback in clinical settings is complex, so that this conversation between the supervisor and the resident, takes place in that really hectic culture, the hectic physical setting. So trying to find time, trying to find a quiet place to have a conversation, trying to make it routine, maybe not every day, what will work every week, whatever will work. And that, what we're hearing is that using a model, something like the R2C2, can be an effective way to have that feedback conversation and also to begin this notion of coaching. What we're hearing from supervisors is that it removes some of that angst. Putting the focus on getting better and improving removes that angst about giving negative feedback. And so using that language of getting better, the best you can be, improvement, can remove some of that anxiety for the supervisor as well as for the resident and make it an easier task. So in summary, the feedback is actually what your observations are. It cultivates the insight into current performance, and it's the coaching that really promotes that future performance and promotes the improvement. So just as I finish up, I'd like you to return to Chris and think now if there are any tips or any suggestions perhaps in the talk over the last few minutes that you might now integrate into your feedback session. Like, we might think about what kind of data, what kind of observations do I need to make? What kind of specific detail do I need in order to be able to help him improve? What might be a realistic plan for him to improve? Might be some of the kinds of things that you might be thinking of. So thank you very much. I hope that's been helpful, and I'm not sure at this time now for questions or comments. There's 1 minute, or we can hold them. I know there's discussion later on. 5? Okay. Again, he says 5 minutes, so 4. We all have trouble with time. Thank you for your help. But if there's any comments or observations, I'm happy to take them now or over lunch or at the discussion later on. Okay. I would say thank you very much. Thank you.